Good morning, good afternoon, good evening from where you ever are hearing us from. I am honored today representing the IFCC and the IFCC Committee on Clinical Applications of Cardiac Biomarkers. We have a wonderful presentation today on analytical and clinical aspects of natriuretic peptides. We have three outstanding and very knowledgeable speakers. We have Professor Torbjørn Omland from Norway, Professor Allan Jaffe from the United States, and Professor Kristin Moberg Aakre from Norway also. So I'm not going to delay. I'm just going to move right to our first speaker, Dr. Omland from the University of Oslo, who will be our first presenter. Torbjørn.
Thank you, Fred. So it's a great pleasure for me to give a talk about natriuretic peptides as tools for diagnostic and prognostic assessment and their current clinical use. And these are my disclosures. So I think we all can agree on that in 2024, the use of natriuretic peptides as a tool for diagnostic and prognostic assessment is very well established and actually integral to heart failure definitions and several professional guidelines for heart failure. For instance, in the quite recent universal definition of heart failure that was published in 2021, elevated natriuretic peptide levels is one major corroborating criterion. And in that definition, elevation of natriuretic peptides, here exemplified by NT-proBNP, is 125 nanograms per liter in the chronic or ambulatory setting, and higher, 300 nanograms per liter for those patients being hospitalized or in the decompensated setting. So if we look to the European Society of Cardiology heart failure guidelines, also BNP and N-terminal proBNP are recommended diagnostic tests in all patients with suspected chronic heart failure with a class 1 level B recommendation. And if you look for diagnostic algorithms for chronic heart failure, NT-proBNP or BNP are included. And similarly, in the diagnostic workup algorithms for new onset acute heart failure, BNP, NT-proBNP, and also mid-regional pro-INP are mentioned, and the cutoffs are set in the acute phase at 100, 300, and 120 picograms per ml, respectively, for these three biomarkers. And it's not only in Europe, but also in the US, the American Heart Association, together with the American College of Cardiology and the Heart Failure Society of America, have published guidelines where they also give a high degree of recommendations. For instance, in patients presenting with dyspnea, measurement of BNP or N-terminal proBNP is useful to support the diagnosis or exclusion of heart failure. And moreover, elevated concentrations of BNP or NT-proBNP supported diagnosis of heart failure are useful for prognostication and may guide further cardiac investigation. And finally, in patients hospitalized for heart failure, measurements of BNP or N-terminal proBNP at admission is recommended to establish prognosis. Also very interesting, other professional societies beyond the cardiovascular ones, for instance, the American Diabetes Association, have recently also published a consensus statement on heart failure and an underappreciated complication of diabetes. And in those consensus recommendations, they state that measurements of a natriuretic peptide or a high sensitivity troponin is recommended at least annually in those patients who are in stage A or B. Stage A meaning those with high risk for heart failure, and stage B meaning those who have already structural changes, but not yet any symptoms of heart failure. So the question is then, what are these recommendations, what data are these recommendations based on? And this goes back to the start of the history of the natriuretic peptides. They were, as you may remember, discovered in the early 1980s. And in 1986, an Austrian group of investigators published this paper in the New England Journal showing that atrial natriuretic peptide, or ANP, were closely correlated with atrial pressure, both on the right and the left side. And this sparked many clinical studies. This is just one example from the studies of left ventricular dysfunction, or SOLD, showing that if you measured ANP in patients with symptomatic systolic heart failure, their ANP levels were markedly elevated compared to a control group. And patients who had asymptomatic left ventricular dysfunction had intermediate values. And what you can appreciate is that ANP seem to discriminate better than other biomarkers that we know are elevated in heart failure, such as norepinephrine, plasma renin activity, or plasma vasopressin. So in the late 1980s, another natriuretic peptide was first discovered in the pig brain, and it was called brain natriuretic peptide, subsequently renamed to B-type natriuretic peptide. And what a group of Japanese investigators showed was that, led by Mukuyama in this paper published in JCI in 1991, was that BNP was elevated in proportion to heart failure severity, but also importantly that BNP levels are higher after the blood has passed through the heart, suggesting that the cardiac ventricles in particular were the predominant source of BNP in the circulation. However, the study that really pushed BNP testing into the clinical arena was the breathing not properly study, and the main results were published in this article in the New England Journal in 2002. And I was fortunate as a young cardiologist to be part of the steering committee of that trial and leading the recruitment of patients in the Norwegian center. And as you can appreciate, this study using a point-of-care BNP test not only showed that there was an association between New York Heart Association functional class and BNP, but also that in patients presenting in the emergency department with a main complaint of acute dyspnea had markedly elevated BNP levels compared to the control group. And if we plotted the sensitivity and 1- specificity of all the observed values, we ended up with an area under the ROC curve of 0.91. That was really impressive. And not long after, similar results were obtained for N-terminal proBNP. Jim Januzzi at the Massachusetts General Hospital led a single-center study showing that NT-proBNP also discriminated very well between those who had dyspnea due to a cardiac cause versus those with some alternative cause, for instance, pulmonary disease. And the area under the curve was even a little higher, 0.94, but I think most people agree that BNP and N-terminal proBNP have comparable diagnostic performance for heart failure. So I think when we are going to interpret BNP and N-terminal proBNP levels, we must always look at the clinical context. And I think one sort of paradigm that has been introduced and which I think is useful is to distinguish between dry and wet BNP or N-terminal proBNP levels. So if we have a patient who is clinically stable there will be some fluctuation about it, some variation of the BNP or N-terminal proBNP levels in the range between 25 and 40% perhaps. But what happens when the patient is starting to decompensate, even before he becomes symptomatic, is that the natriuretic peptides levels will increase until the patients become decompensated and symptomatic and in a state of fluid overload. And the BNP concentration at that point is what we call wet and BNP, or wet N-terminal proBNP levels. And after the patient has been admitted, what usually happens, he or she will receive medical therapy that will tend to reduce cardiac filling pressures, and also natriuretic peptides levels will drop. And after a course of stabilization, when the patient is discharged, hopefully he will be properly compensated, and again in a dry BNP or N-terminal proBNP phase. So the wet natriuretic peptide concentration sort of reflects volume, the acute volume overload associated with decompensation of heart failure, whereas the dry natriuretic peptide level is what you chronically observe in the well-treated patients, and that will then really reflect chronic dysfunction of the heart, and also a remodeling of the ventricles. So this is a recent figure published last year by the Heart Failure Association of the European Society of Cardiology, and it sort of summarizes, I think, in a nice way, the way we currently use natriuretic peptides to diagnose or exclude acute heart failure. So if the patient presents with a history compatible with volume overload and signs and symptoms reflecting congestion or hyperperfusion, we use natriuretic peptide testing to categorize the patients, either to rule out if the BNP, N-terminal proBNP, or MR proANP levels are low, and if they are elevated or high, we can rule in heart failure with a high degree of probability. But there will be a gray zone where the diagnostic performance of the natriuretic peptides are not that great, and ancillary testing with chest X-ray, lung ultrasound, echocardiography, etc., will be required. It's also very important to remember that there are alternative causes of higher natriuretic peptide levels than heart failure, and we can divide them broadly into cardiovascular causes and non-cardiovascular causes. And among the cardiovascular causes, we include acute coronary syndromes, acute myocardial infarction, but also conditions like pulmonary embolism, myocarditis, arrhythmias, etc. Among the non-cardiovascular causes, high age, advanced age, and also kidney disease are among the most important factors that could result of elevated natriuretic peptide levels. Also in conditions like sepsis, it's common to observe quite high levels. And conversely, there are also some, not very many, but there are some important causes of lower natriuretic peptide levels that it is important to remember. And I think maybe most important is the fact that obesity is associated with quite markedly lower natriuretic peptide levels. There are also some rare instances of very abruptly onset of pulmonary edema, flash pulmonary edema, where the initial testing will show unexpectedly low levels of BNP and N-terminal proBNP. So please remember these important factors. So if we are going sort of to summarize, how should we deal with natriuretic peptide testing in the emergency department if there is suspicion of heart failure? We should measure the natriuretic peptides, and we should remember that this is a wet natriuretic peptide level reflecting volume overload, and we can then sort of divide or categorize the patient into different strata. If the level is below 300, if the N-terminal proBNP, for instance, level is below 300 picogram per ml, we can rule out heart failure with a high degree of certainty. And then there is the gray zone, and then we use age-adjusted rule-in cutoffs based on the ICON and ICON Reloaded study. So for those younger than 50 years, cutoff or a decision threshold of 450 picograms per ml is used. In the range between 50 and 75, 900, and above 75 years of age, 1800. And then there's a fourth category consisting of patients with very high BNP or N-terminal proBNP levels, and those patients are at particularly high risk. So in the outpatient setting, the patients are usually less sick, and the cutoffs we use are lower. So for N-terminal proBNP, as an example, it's the decision threshold for rule out is 125, and there's the gray zone, and then again age-adjusted rule-in cutoffs 125 for those below 50 years of age. 250 for those between 50 and 74, and 500 for those above 75 years of age. And then if we look of those who have risk factors for heart failure, but not yet any symptoms or maybe not even structural changes, there has also been recommendations for using natriuretic peptides in this setting, and then again with an even lower rule out and age-adjusted rule-in cutoffs. But the way of thinking of reasoning is the same, that we can use a rule-out cutoff, there is a gray zone, and then age-adjusting rule-in values. So what about natriuretic peptides as tools for prognostic assessment? And there are many studies that have shown an association between natriuretic peptide levels and outcome across the spectrum of cardiovascular disease. I'll just mention some examples. Back in 1996, we were among the first to observe or to demonstrate an association between BNP levels measured in the subacute phase of acute myocardial infarction and subsequent survival. And a few years later, we also confirmed that relationship using N-terminal proBNP measurements. Again, discriminating very well between patients with a good versus a more adverse prognosis. And in chronic heart failure, Anand and colleagues, also in a paper in Circulation in the early 2000s, showed that BNP was a far better prognostic indicator than norepinephrine. And even in patients who are with stable cardiac disease, stable coronary artery disease, and without any signs of heart failure, preserved ventricular function, an N-terminal proBNP level is highly predictive of subsequent development of heart failure. And just for also showing you more recent data, this is from the SAVOR Team 53 trial, which was a huge study, more than 16,000 patients with type 2 diabetes, but again, confirming a very strong association between N-terminal proBNP levels and the risk of heart failure. And if we use proteomics approaches and measure many biomarkers, this is a study looking at a large cohort with stable coronary artery disease, and N-terminal proBNP is consistently ranked as the best prognostic indicator, even if you compare with many clinical factors as in this study. And here, Amil Shah from the Dallas Heart Study and Eric, together in a collaboration with our group, recently published in Nature Communications, and that N-terminal proBNP is the strongest biomarker predictor of heart failure, even if you compare with 7,000 other biomarkers. So in summary, and some key principles at the end, it's important to remember that natriuretic peptides should always be measured and interpreted in conjunction with all other clinical information. They do not replace clinical judgment. Secondly, natriuretic peptides should be measured in all patients presenting with symptoms suggestive of heart failure, such as dyspnea and or fatigue, as their use facilitates the early diagnosis and also risk stratification of heart failure. Furthermore, natriuretic peptides have very high diagnostic accuracy in discriminating heart failure from other causes of dyspnea. The higher the natriuretic peptide concentration, the higher the likelihood of that dyspnea is caused by heart failure. As I have shown you, optimal natriuretic peptide cutoff concentrations for the diagnosis of acute heart failure in patients presenting to the emergency department with acute dyspnea are considerably higher than those we use in the diagnosis of chronic heart failure. Importantly, obese patients have lower natriuretic peptide concentrations, which mandates the use of lower cutoff concentrations. And moreover, natriuretic peptide concentrations have high prognostic accuracy for death and heart failure hospitalization across the spectrum of cardiovascular diseases. And if we go to screening with natriuretic peptides for the early detection of relevant cardiac diseases, including left ventricular systolic dysfunction in patients with cardiovascular risk factors, that may help to identify patients at increased risk. And that again can allow targeted preventive measures to prevent heart failure. I think most data support that BNP, N-terminal proBNP, and mid-regional proNP have a relatively comparable diagnostic and prognostic merit. And finally, natriuretic peptides cannot identify the underlying cause of heart failure, and therefore, if you measure an elevated value, it must always be used in conjunction with other diagnostic testing, including cardiac imaging. So thank you very much for your attention.
Thank you, Torbjørn, for the excellent clinical update on natriuretic peptides. For the audience, we're going to reserve all questions till after all three speakers have presented. So we will now move on to our second speaker. It's a colleague, a good friend, also a consultant to the IFCC Committee on Clinical Applications, as Torbjørn, Professor Allan Jaffe from the Mayo Clinic in Rochester, Minnesota. And Allan has a unique background in the sense that he not only is a practicing cardiologist, but is very knowledgeable and has been served as division director of laboratory medicine in the Mayo Clinic. Allan.
Thank you, Fred. It's my pleasure to be here and to talk about the use of low concentrations of natriuretic peptides. Please note that I have consulted for most of the diagnostic companies in the world. Sometimes they like me, sometimes they don't. But it's somewhat different looking at low concentrations. Most, although not all of the data that Dr. Omland shared, utilize values that are fairly high. And those higher values don't begin to impinge on some of the issues related to sensitivity, specificity, accuracy, and precision, which Dr. Aakre, I'm sure, will talk about a little bit. But what it means is that some of the issues that we don't have to pay as much attention for when the values are very high, because the dynamic range is so very high in those, may not be as relevant. But I would urge you, as we go through this talk, to keep in mind the fact that BNP values change over time related to age and gender for both BNP and NT-proBNP. And this may become important if we're looking at small changes or small differences. There also are circadian differences that could turn out to be important. This is just one example of what happens during the day. Values for BNP and NT-pro are lower in the morning than they are during the rest of the day. There also are differences related to ethnicity. Here, looking at blacks versus whites. And as Dr. Omland pointed out, very substantial differences in regard to weight. And finally, differences related to therapy. This is just one slide that came from the sacubitril/valsartan trial on Entresto, suggesting that there might be differences related to therapy. In addition, there's a lot of biologic variability that needs to be taken into account. So as you start to think about the small differences that we're talking about with some of the use of the low values of natriuretic peptides, keep in mind this sort of week-to-week variation, because this could be confounding and terribly important for us to understand. But the area of using relatively lower values to anticipate or to predict the eventual development of heart failure is not novel at all. These are data published from the ERIC trial, looking at both troponin and NT-proBNP, and suggesting that there is a continuous relationship in both men and women, but note there may be some differences related to those analytes between the two groups, that the lower your values, the less likely you are to develop 10-year risk of heart failure, and the higher the value, the more likely you are. Now, some of these values are somewhat elevated because there are people who are in the community who walk around who have heart failure and are unaware of it. So these are undetected individuals. But there also are individuals who have some structural heart disease who have not yet been rendered symptomatic at all, who also are out there, and even more individuals who are at fairly high risk, for whom there is information provided by both troponin and natriuretic peptides. We followed that study in a study that we did here in Olmsted County, looking at heart failure and mortality using a high sensitivity assay. At the time, it was a prototype high sensitivity Siemens assay, and BNP values utilizing the 80th percentile of the normal range. Okay. And what you can see is that if you have higher values of troponin or natriuretic peptides alone, in the two middle lines, or both, the frequency of heart failure over a long-term follow-up was quite high and quite elevated. And again, these values are selected intentionally to be still within what would be considered the normal range for both natriuretic peptides and for troponin. So these are not levels that are formally elevated. So why should there be prognostic values to low biomarker values? Well, maybe we've misdefined normal. And we certainly could make arguments that because the levels of natriuretic peptides used in the breathing not property trial, in Jim Januzzi's trial of NT-proBNP, in ICON, were in heart failure patients, they really were quite elevated. And maybe we didn't probe as carefully the normal range studies. So there's at least a question to be posed there for you to think about. Secondly, these increased values could indicate a lack of reserve. All of us have varying degrees of biologic activity, but we also, when we're stressed, need to be able to increase things like cardiac contractility and the like. And perhaps the changes in natriuretic peptides that are counter-regulatory to some of that lack of reserve are there not because there is a real abnormality, but as a manifestation of that lack of biologic reserve. 3, you could have factors outside those directly related to the disease process that also impact on the disease process. In this instance, since we're interested in cardiovascular disease and predominantly heart failure, you could say, okay, maybe those values are, the heart is okay, but something else outside the heart is contributing to the abnormalities that we see and may be related in the long term to an increased stressor that manifests itself with more heart failure. Just one example, this is the relationship between natriuretic peptides and NT-proBNP specifically and measures of EGFR. And what you can see is that the lower the EGFR, the higher the natriuretic peptide levels. Even if you think that this is an isolated phenomenon, there isn't a relationship between the EGFR and the heart. And we all know that there is some. Some of this will, in the long term, reflect the inability to deal with salt and water and will be a stressor that will potentially contribute to the development long term of heart failure. Now, it's also possible that these values really, because they're counter-regulatory, they predict that there is an underlying unappreciated disease process. And this is where the field is starting to go, and which is very important that everybody understand, because we now have agents, as I'll show you in a few minutes, that potentially could be helpful to these patients. And the schema that was shown by Dr. Omland before is an important one. This was redone as part of the American Diabetes Association recommendations. But there's stage A heart failure, which says, are you at risk of developing heart failure? And diabetes, for example, and this is why the ADA is involved, is targeting that group and saying that diabetics are at high risk, so they need to be evaluated on a yearly basis to see whether or not there is an abnormality in the biomarkers that would suggest structural disease, and as Dr. Omland pointed out, lead one to do additional studies, i.e. imaging. predominantly looking for what we call stage B disease, which says that there are structural abnormalities that we can detect. So the heart is no longer normal. This is considered stage B heart failure and actually part of heart failure. And if that's true, then heart failure treatment may be efficacious in this group. That's to distinguish the occasional patient in this same area who might have more overt disease, but who is unaware of it. Now, even before we had the more sophisticated agents that I'll mention in just a couple of minutes, it was known that by identifying these patients who were in stage B, if you will, might make a difference in terms of their long-term trajectory and whether or not they develop heart failure. This is a trial done by John McMurray in Europe called Stop HF. And basically, individuals who were going to their general practitioner had a blood test done. If the BNP value was 50 or lower, and that was very arbitrarily defined, those patients could be followed. If it was over 50, they were randomized to either seeing a cardiologist, which meant additional testing in most instances, or follow-up. These are the representative characteristics of the varying groups. And what I've highlighted for you is the fact that if you look, the patients who tended to have the higher BNPs tended to have slightly more glucose intolerance, a little more hypertension. So it's clear that they were identifying a risk group. If one looks subsequently, in those individuals who had the elevated BNP and who were put into the intervention group, meaning they saw a cardiologist and had some additional testing, some of that testing, if indeed they were one of these individuals who had congestive heart failure that was unappreciated by the patient, may have had more extensive intervention. Some of this may just be identifying structural heart disease and saying, hey, this person has hypertension that is less than ideally controlled, or diabetes that is less than ideally controlled, or some other stressor. So it's heterogeneous. But what you can see is that there was a mortality benefit as well as overall a benefit in terms of major cardiovascular abnormalities. And if you look here again, we're talking about a variety of parameters. I've tried to put the ones that are in red to show you that much of this had to do with individuals who were not terribly symptomatic. So this was the first trial that suggested we could really not just identify, but impact on the prognosis of these individuals therapeutically. There was a subsequent trial called Pontiac, not the car that is made in the United States, which looked at diabetics, used an NT-proBNP value of 125, and randomized the individuals to either lisinopril or placebo. And if you had a high natriuretic peptide value and you were randomized and you're diabetic, you would get an ACE inhibitor, which gives you both renal protection as well as vasodilation and therefore some potential cardiac protection. And there was a significant difference in hospitalization or mortality by 24 months. If one looks, you can see this was mostly cardiovascular event and mostly heart failure, not so much mortality. Pontiac 2 has been done, and my understanding is that Pontiac 2 has been closed, and I'm not sure I know the results yet, other than the fact that we were told, or what the rumors on the about it are, that this study was subsequently null, and we'll have to see those values. Nonetheless, it turns out that what has happened in the interim since Pontiac and other trials is that new agents have been developed, in particularly so-called SGLT2 agents, sodium glucose cotransport inhibitors. Now, this is just a slide of a variety of mechanisms. Nobody really understands totally what the exact biochemical mechanisms by which SGLT2s work. They clearly increase natriuresis. They clearly improve renal function, but it's more likely than not that there are a variety of different mechanisms. And since most of these are speculative, for which there is indirect information rather than direct information, I'm not going to focus on them, only to say that these agents are a game changer. Why? Well, this is just one from one trial of one agent in diabetics, published in the European Heart Journal, to give you a sense. But most of the trials show the same thing. Very substantial reductions if one takes patients who have diabetes and heart failure of any kind. And these differences are not trivial. You know, they're 30, 40% reductions, both in heart failure, renal failure, all-cause hospitalization, very potent effects. Interestingly, and important from the point of view of where the future will be, is the fact that when these trials were expanded, and I just took this as one example, it's from a meta-analysis of non-diabetic patients, the same thing is seen in all patients, not just diabetic patients, with a reduction in all-cause heart failure in patients with reduced ejection fraction, patients with so-called moderate ejection fractions, that is to say, between 40 and 50 is a group that is not quite HFpEF, but not as overtly ill as those with heart failure with reduced ejection fraction, and showing benefit. And I haven't shown it, I didn't put the slide in, but there now are data in patients with heart failure with preserved ejection fraction. So we now know that if we can identify patients who have heart failure, most likely, although the analyses have not been done specifically as well as one would like for the stage B patients, that it's very likely that one can markedly affect the prognosis long term. Given this, the Diabetes Association has taken a very aggressive stance, and you saw this slide earlier. They're saying every year you need to check and make sure that individuals have not gotten to stage B, that they stay in stage A. If they are in stage B, the implication is that this would be detected by imaging if the biomarkers work as one would hope that they would, and that these patients would then very likely be treated with agents like SGLT2 inhibitors. It's not as easily said as done. These are more expensive agents, at least in the United States, but that's the concept. And you'll also identify these individuals. So the diabetes groups have taken a very strong stance of saying we want to identify these patients. When you look at their statement, and I'm not going to immerse you in this, they go through the studies and they list them all, But the important thing to note from this slide is that the cutoff values that are used in all of these studies vary tremendously. So that we're not at the point where one can say we know for sure what the best cutoff values in any given individual is. And that's why I started out with those early slides to sensitize you to the fact that this may be different in an older woman, may be different in a Black individual, may be different depending upon the time of day that you decide to probe. This is terribly important. Nonetheless, they took a shot at it and said useful cutoffs are a BNP of 50, an NT-pro of 125, and high sensitivity greater than 99th percentile. Those are not unreasonable cutoffs from my perspective, but I would point out to you and to each of you who are thinking about this as clinicians who will eventually be dealing with these patients, the data that I showed you both from Eric and our own data that suggest that even very lower values, that there is a continuum. So these values may be too high for some, maybe too low for others, and there is most likely going to need to be some degree of individualization that is applied depending upon the person who you see in front of you, which is why Dr. Omland's emphasis on the need to put everything within the clinical context is so important. What is a second group? The Diabetes Technology Society that also has weighed in. They weighed in and suggested a value of 35 and less than 125 to look at this stage B disease. Again, not unreasonable, but clearly going to have some confounds depending upon the ability of the assays and the clinical data and clinical covariance to allow us to use those. And the Diabetes Technology Group was careful. They suggested that you start measuring this at the age of 30 or at the age of diagnosis. The duration of diabetes, they argued, should be no earlier than the age 30 and 5 years following diagnosis. They suggested it be done annually. They didn't take a biomarker of choice, and they didn't distinguish between time of day, despite the known variability that I showed you early on intentionally, because I knew this point was coming, that might be relevant in terms of assessing a given patient. Finally, the Heart Failure Association of the ESC has weighed in as well with their own recommendations. Some of this Dr. Omland has shown you already. They have 3 levels. One, if you suspect heart failure in the outpatient setting. They suggest a rule out, a gray zone, as Dr. Omland indicated, an age adjustment, which I'll show you in the next slide, to use if you suspect heart failure. That means you probably have a symptomatic patient with dyspnea. And they suggested these cutoffs, that there be age-related cutoffs, taking into account, in particularly, the known proclivity of women and older individuals to have their values go up in terms of the cut points. And notice they are very careful. The cut points are non-obese patients without kidney failure and without atrial fibrillation and flutter, which also cause increases in natriuretic peptides. They say you can also screen, which is what the American Diabetes Association was getting to. And for those sorts of screening proposals, they suggest a rule out of 50, and age adjustment as well. They also suggest that one do this year after year, reevaluation every 6 to 12 months for diabetics, looking for heart stress. I would point out to you, and I'm not going to go into detail with this, this is a summary of some of the biologic variation studies and the reference change intervals that might be relevant. Notice how high they are. That is to say that if you're going to be doing this every single year, the likelihood of seeing some changes, unless there is more consistent protocols to make sure that the data are trackable and that one can use the trends intelligently, is likely to become confounding. Now, the diabetes group has led the way by being the biggest advocates for this sort of approach. But it's diabetics today. Tomorrow, it rates to be the world. Because all of us, if one starts to look as one ages, will have some cardiovascular comorbidities that will put us in that higher risk group. So thinking about this as how we apply these to diabetes is the first step. But we need to understand that eventually, as clinicians, this is something we're going to be doing on a much larger number of patients over time. So we need to take these things seriously, as well as the caveats that Dr. Aakre will share with all of us about the analytics that need to be taken into account as well. With that, I'll stop. Thank you very much.
Thank you, Allan. One of the questions I might pose to everybody at the end is this going to be something like a cholesterol test? When do we start? Into who do we start to measure these natriuretic peptides in? But thank you. I look forward to the question and answers. Our final speaker today is the chairman of the Clinical Applications of Cardiac Biomarkers for the IFCC Committee, Professor Kristin Aakre. And we've been colleagues for many years, and she's going to be our speaker that is going to address the analytical and the laboratory medicine side of biomarkers regarding natriuretic peptides. And I'm really looking forward to your talk, Kristin. Thank you very much for being here.
Thank you for the very kind introduction. Yes, I'm going to talk about the analytical side of this and what analytical quality is really needed. And yes, here are my disclosures. And this is the overview of my talk. So first, I'm going to start really basic, and I apologize for those of you who think this is too simple. But of respect for those clinicians who are not so experienced, I will talk very basically about the analytical performance specification. What is that? And how we decide what analytical performance is needed. And then I will go more into the details on natriuretic peptides and what is needed there and what is currently reported for these assays. So what do we mean by analytical performance specifications? Well, this is really basic, what we deal with in the lab every day. It's the imprecision, it's the bias, and it's the total allowable error. So imprecision is, you all know this, but this is measuring the same sample several times. And we can do that within the same series, usually within the same day, or we could do that over time, like once every day or twice every day or something like that. And then we plot the data like here, and you see the variation in the chart. So this is the concentrations on the y-axis and the time on the x-axis. And then when you have 20 to 40 measurements approximately, you can start calculating your CV, and that is the standard deviation of these measurements divided by the mean concentration. So that's That's how we usually measure our analytical variation, and you get a nice bell curve as shown here, where you can actually see how your variation is. It's normally distributed. And we use these to measure the quality within the lab. So, and most of us will then use the Westgar rules. And if we have a measurement of a control sample, that is, for instance, if we have a control rule of 3S, and we have a measurement of the control which is outside 3 standard deviations, then we will have an alarm. There are other rules. We very much use 2S and plus 3S, which means if there is one measurement outside the 2 standard deviations, we will remeasure, and if it's then outside 3 standard deviations, then there is an alarm. So that means if you have an alarm, you need to actually find out where is the error and why do you have this large deviation from the accepted mean variation. Now, mean concentration that you have for your control. So that's how we use the analytical variation. And then it's the bias, and the bias is just systematic deviation from the target concentration. So you have decided which level your assay should be on, and you have a sample where you measure every day, and that is your target. And then if you have some changes in the assay, which gives you a systematic deviation, it's not just one sample that is outside 3 standard deviations, it's every sample which has changed the level, then you have a bias. And the goal is always to eliminate the bias. It's not something that we want to have in our assays. So we try to eliminate them, but it's not always possible. And I will show you a little bit when it's difficult. For instance, lot variations, that is kind of the interplay between the imprecision and the bias. And I don't know if you can see my pointer here, but if you start here, you see the first part of the chart. There you have many control samples, and they are varying around a mean value. And then suddenly, after the lot change, there is a shift, and everything drops down to a new level. And then you have another lot shift, and it comes even further down. And then again, a new lot, and then it's increased again. So then you are on a higher level with your assay. So this is depending on how you have decided to measure your CV. You can either include all the lots, and then you will have measure the total variation. Or if you measure the variation for every lot, you will have a much narrower CV for your assay. But you will have these shifts where you suddenly measure a lower or higher concentration, depending on changing the lot. And we usually do this with internal quality control material, but what I recommend is that, I don't know if you can see here the red spots within the blue, and that is patient samples. So what we do recommend is that you use either a serum pool or a plasma pool or whatever is available to you, and you include that with your controlled sample, with your commercial controls, because the patient samples, they actually show you what assay shifts are applicable to patients, because the commercial controls are sometimes manipulated so that the lot shifts will not come through, and you will not see these changes when you change the lot. But the patient samples, they will reflect what actually happens if you have a patient pool then you can see what actually happens when you change the lot, if it goes up and down. So if you include all the different lots in your calculation of the CV, you will have the total CV. But if you do it independently for one lot, you will only have the short-term CV. So that's just important to be aware of, how these things, what you are actually measuring with your CV. So then it's the total allowable error, and that's the combination of the imprecision and the bias. As I showed you, the long-term variation will include the lot variations, and then you can hopefully say that the bias is 0. But it could also be that you have some bias due to, I don't know, the tubes you are using, or the storage of your samples, and those kind of things, which you have not been able to eliminate. So then you will have a bias included, but try to eliminate it if it's possible. What can also be included here in the allowable error is, of course, between laboratory variation. Then you need usually to do it in an EQA program to detect that. And then it's the random error, of course, also. So why is analytical variation so important? Well, imagine you have an absolute cutoff here of, gentlemen before me have told you a lot about cutoffs, but say you have an absolute cutoff here of 100, and those above 100, they are diseased or at risk, and those below are not at risk, they are healthy. And then, just due to analytical variation, half of the patients who have a concentration of 100, they will be measured below the cutoff, and half of the patients who have will be measured above. And this applies to those who have a concentration which corresponds exactly with your cutoff. However, what about the patients down here, which maybe only have a concentration of 50, which is truly healthy? Well, due to the analytical variation, there is still a small chance, as you can see above the black line here, there is still a small chance that this patient will be measured above the cutoff and then be misclassified as being at risk. However, it's only a small risk when we have the analytical variation that is shown here. And that is, as I told you earlier, reflected by the shape of this bell curve. However, if we have a larger analytical variation, which is shown here, the bell curve is much broader. And then this poor guy here, who have a concentration of 50 and is truly healthy, has a much larger risk of being misclassified as above the cutoff and at risk. So that is why we want to have a narrow bell curve. And we don't want to misclassify the patients. However, as Professor Jaffe already told you, we have something called biological variation, which will make every person who has a concentration of 100 will fluctuate around that set point, and sometimes be above and sometimes be below. And we don't need to have an analytical variation which is much better compared to the biological variation, because we will not be able to detect to classify them correctly anyway. But I will come back to that a little bit later. So why is analytical bias important? Well, this is from a paper we published just earlier this year, and it shows you exactly the same thing. Here you have 50% of the seized is above the cutoff and 50% is below. That is, if you have somebody who has a concentration of the biomarker in the blood, which corresponds exactly to the absolute cutoff. So 50% above, 50% below of the measurements of that patient. However, if your assay is shifted downward due to, for instance, a lot, you get a new lot, and this lot is lower compared to what it should be. For instance, it's 1 standard deviation lower. Then you will not have 50% of measurements in this person below and 50% above. Actually, it will be 84% of the measurements that will be below the cutoff and only 16% above. So then there is a high risk of misclassifying this patient as low risk. And if you have if you have a shift of 2 standard deviations, it's going to be even worse. Then it's only 2.5% chance that those patients who have a concentration exactly similar to the cutoff will be measured above the cutoff. So then you can shift your whole population downward. And like when I showed you earlier with the analytical variation, well, that only applies to one person. That's a risk in one person. But here, it's a risk for the whole group you are measuring. And then if there is a large percentage of the cohort you measure who are around the cutoff, who has a concentration which is around the cutoff, and you shift that large group downward or upward, you will misclassify large percentages of patients. So therefore, bias has often a much larger impact of the classification and misclassification of patients compared to analytical variation. So how do we decide what analytical performance is needed? Well, this is from a publication in 2017. There was a strategic conference in Milan in 2016, where a lot of good old men sat down to decide strategies to define performance specification in laboratory medicine. Or maybe it was even in 2014, because it says it's 3 years from the conference. Anyway, this conference decided and discussed what kind of analytical performance specification we should have and how we should define them. And what they first said, that was a hierarchy of the performance. So ideal is like the perfect one. And then most of us will be satisfied if we could have a desirable performance. That's what we usually aim for. And they set up different models how to decide the analytical performance specification. And number one was actually that we should decide the test performance based on clinical outcomes. And that means actually that you should take your patient group and you should randomize them to poor analytical quality and high analytical quality, and then you should calculate how that affected the outcome. For instance, rehospitalization could be an outcome, death could be an outcome, and so on. And you should actually randomize patients and see how the analytical quality affected their health. That is very, very rarely done. Very rarely. What is much more common is number B here, which is indirect outcome studies. And here you actually either did simultaneous simulations, or one could also do a decision analysis, and one would see based on the analytical performance of the test, what were the probability of patients being diagnosed or with a condition or being admitted to hospital and that kind of things. And we have done that here. We have taken all the patients who were measured for troponin T in the ED, and then we used a cutoff of 5 nanograms per liter, which is a rule-out cutoff for endostemy, which has been suggested by the European Society of Cardiology. And then we looked at the different lots of troponin and saw how the rule-out rate would vary depending on lots. And then we could show that if you had higher or lower lots, that would actually affect how many patients who were suggested to be ruled out or who were suggested to be admitted. So that's the typical indirect outcome study. What is the most common model to use is number 2 here, which is biological variation. And the last one is state of the art, which actually means the analytical quality the assay can provide. So for natriuretic peptides, what analytical quality is needed? Well, I haven't seen many outcome studies, and the clinical guidelines, for troponins, there is guidance in the clinical guidelines how good the analytical performance should be. There is no such thing for natriuretic peptides. So they don't say anything specific about how good the analytical variation should be or the total allowable error. But they say something about which cutoffs are important to monitor. And that is what has been already pointed out by Professor Omland and Professor Jaffe, the cutoffs given in the guidelines. And for NT-proBNP, we typically use 125 to rule out chronic heart failure, and we use 300 to rule out acute heart failure. So it would be very wise to monitor your NT-proBNP assay around those cutoffs. And for BNP, it's 35 and 100. So similarly, the assays should be monitored around that cutoff. We also have this very recent position papers, which was published a short while ago, which suggests a cutoff of 50 for NT-proBNP, which is quite low, very low compared to what is usually available. Regarding biological variation, I would recommend that you all go into the EFLM database, and because they provide these measures for nearly all biomarkers. However, and what you do here, then you just type in the biomarker you need, and you click on the analytical performance specifications, and they provide it for you immediately. However, as you can see here, this is example for troponin I, and the problem is there is not yet any data available in the database for natriuretic peptides. However, I talked to them last week, and they say it will be available next year. So what you can do while we wait for this, we have to just go calculate it ourselves using these formulas, which we are familiar with. And then we need to go into the PubMed and find the biological variation studies, which I have show you some examples here, and Professor Jaffe has also showed you some examples. So as you can see, many studies suggest quite high cutoffs for the CVI and the CVG, the within and between subject variation. However, there are some studies which suggest quite low percentages for variation, and if we use different percentages suggested by these studies, we get an analytical CV that should be quite low if we use the lowest estimate, but higher if we use the higher. And I don't know what exactly the EFLM will come down on, but it's going to be somewhere around here, maybe in precision of around 10% and bias the same. So that is quite low numbers, but we need to wait and see until next year what they actually conclude on. They have a very rigid system for which studies they will accept and which studies they will not accept into the database. So regarding what is available, I just recommend that you go into the IFCC webpage and look at the biomarker reference tables. And there you can see the CV for all the different assays. Find your own assay and look the CV at the LOD or LOQ and at the upper reference limit. And there is also data on interference in those at that web page. So please go and check on that. Finally, somebody asked in the chat about EQA data. There is one recent study from Equalis which shows the long-term CV for different manufacturers, large assays. And as you can see, this is the low sample they circulated. Is for most of the measurements, it's below 10%. So it's quite good, actually. This is the total CV included also between laboratory CV. So to conclude, analytical performance specifications for natriuretic peptides are currently guided by biological variation data. The limits based on biological variation seems wide, and the state of the art as reported by the manufacturers seemingly meet these criteria. However, we need to wait for the meta-analysis from the EFLM, which will be ready next year. And if I could make a wish, I would love to see more data on total variation from real-life settings like this from Equalis, lot variation, and indirect outcome studies. Thank you.
Thank you very much, Dr. Aakre. It adds quite a bit to our clinical colleagues. And I think it's time that we, as a group, address some questions. I've gotten several questions from our attendees, and I have a couple to start myself. And I'll start with Kristin, you, and anyone who's had experience with the laboratory. One of the things I did not hear addressed today, unless I was sleeping, but I don't think I was, is the potential concern of samples being used regarding stability. There is a lot of data presented on NT-proBNP, some on BNP, and it was known for years that there's a stability concern with BNP, especially freezing or room temperature for a long time. I guess one of the questions I'd like to hear from the speakers is if people were going to have to pull a sample 6 days out of a refrigerator before it's discarded on patient care issue, is its BNP still stable? And is it assay dependent? I know that's a lot to ask, but those are the type of questions we're receiving. Kristin, can we start with you, and then anyone else that would like to comment?
Excuse me. Yeah, I have a little bit this problem with the line here, but I think you were asking about stability, and that has of course been a problem with the BNP assay, because the BNP assays, they are only stable for maybe in room temperature, maybe for 4 hours. So for us in Norway, it has been really difficult because many of the samples are taken, for instance, by primary care physicians if they want to rule out chronic heart failure in a patient. They will send a sample, and then it's not possible for them to have it measured for a BNP because it takes more than 24 hours to get the sample to the lab, and so then they have to freeze it if they want to measure it for BNP, and that is not feasible, of course, not in primary care. So I think most labs are now offering NT-proBNP because of a much better stability, and then the possibility to receive samples from small hospital, from primary care facilities.
Thank you. Allan or Torbjørn, any comments?
Fred, I think it might be worth adding that there is a heterogeneity of BNP assays as well. They use different antibodies to different epitopes, and the correlation within BNP assays is highly variable. So not only do you have a stability issue unless you take special care to preserve the sample, but you have a potential problem of using assay 1 versus assay 2 be terribly important for clinicians, even if they do things promptly and avoid the stability issues, to use the same assay, and particularly with BNP. NT-proBNP is more harmonized across all of the various platforms.
Yeah. Torbjørn, any comments?
Yeah, I completely agree with what Kristin said, that if there is sort of outpatient samples, then N-terminal proBNP is, of course, has very important advantages. The scenario you presented with 6 hours in the refrigerator, I think there could be impact on clinical if it's very close to the decision limits. But if you have a very high value, then it probably wouldn't play a major role. So it will depend on the clinical context. But overall, I think that NT-proBNP, because of its superior in vitro stability, is the preferred biomarker.
Thank you. Another question that came up had to do with reference intervals and establishing cutoffs. And a lot of work, I know Roche sponsored the, ICON Reloaded study, which I think at least a couple of you referred to. Has something similar been done for BNP? Typically, we're just taking package inserts, and we've heard a lot today about guidelines. But is a similar type of concept been studied with the BNP assays by multiple manufacturers that look at the same concepts that the NT-proBNP did with Roche? Allan Jaffe?
Not to my knowledge. I don't think that any specific company has done specific due diligence in regard to a large study similar to what ICON, which originally was just 3 groups that pooled their data, and subsequently then was sponsored to have a more valid trial across a larger number of sites. I'm not aware that that's been done for any of the BNP assays, and it would have to be done individually for each assay.
Torbjørn, any knowledge?
No, I'm not aware of any quite similar study, but I'm convinced that you would see a similar association, that it would be, that it would be appropriate also to have age-adjusted rule in the cutoffs for BNP. But as far as I know, we don't have solid data to support that.
And the last question along those references, as we all know, there's a decade age-related relationship that often is published in package inserts. Is that something that all 3 of you that's something that we should be looking at when we're establishing ranges?
Well, Fred, the question is an interesting question as to whether or not the increases with age, as in the case of troponin, are due to subtle comorbidities, or they're really part of normal aging. I can tell you our own data, when we've parsed the data would suggest that it's due to comorbidities, unfortunately, as somebody who is in that range where I'm starting to age. So I think it should be treated as if it's a comorbidity, but there was more data in a more definitive manner that is necessary to really answer that question in detail. If it's part of normal aging, then correction for age and sex will be terribly important. And the same thing, it looks like a lot of the variation, the lower values in men relate to testosterone rather than anything else. So individuals, for example, who are receiving testosterone replacement lower their natriuretic peptide levels. This is a very complicated area. There are a lot of covariates. And one of the concerns I have about implementing these low values is how one takes into account all of those covariates.
Thank you. Kristin, there's a question I think maybe going towards you. I know we're running out of time here. I think our 9:30 is our deadline by time. I mean, there's data out there on the EQA results for NT-proBNP vary significantly by manufacturer. We've touched on this. Do the presenters take this into consideration when you're using cutoffs?
Are you asking me?
Anybody. I mean, everyone has to. I think what I've heard today is every manufacturer, even with NT-proBNP today, because Roche no longer has intellectual property right. There are many assays that are being developed.
I think this is one of the really caveats with these assays, because for troponins we have assay-specific cutoffs for every assay, and you cannot get on the market with a troponin assay without establishing the certain cutoffs. For natriuretic peptides, we have one cutoff for BNP and one for NT-proBNP, or several different though, but they are not assay specific, and that of course put a lot of pressure on the manufacturers that they need actually to keep the same level for their assay as what was in the clinical study where this cutoff was established. So they actually have to adjust to the level that was in the studies when the cutoff was adjusted, that was determined. And I don't think that is done. And I don't think we as a laboratory community has been good enough to kind of highlight this to the manufacturers and to ask for it. So I don't think it's completely similar. And I think some assays are closer to the cutoffs than others.
Thank you.
Fred,
I want to get a couple more questions.
Fred,
go ahead.
I would point out that if people are using different antibodies and have different NT-pro assays, they may well not correlate well with the original NT-pro assay, nor with the ICON and ICON reloaded data. And my recollection is that Tor did a study at one point in time where he used glycosylated samples, and that was the case. They gave similar clinical information when one corrected, but the values are different.
One more. I think I have time for one more question, unless I'm cut off. But this is for the two clinicians, or even Kristin too, for everyone. Several people have asked: Is there a need or a preference? Is there a need to have both a BNP and NT-proBNP assay in your clinical laboratory to provide clinical relevant differences that might be useful for patient care?
Not that I'm aware of. I'm not aware of any study that has shown that there is additive information utilizing the two together.
No, I agree. Theoretically, you could argue that because of the different in vivo half-life, that BNP could respond more quickly if there are dramatic reductions in filling pressures and so forth. But I don't think there are any convincing clinical data to support that it plays a major practical role.
And then there were a couple of questions. I know, Torbjørn, you addressed this, and Allan also, about prognostics. Is that typically being used in clinical practice? I mean, you talked about dry and wet values. I know some people have suggested getting a value before you send a patient home. Is that being used for prognostication in an outpatient basis or for therapy? Could you comment on that?
Yeah, I think it's increasingly used that you have both on admission and then to see or to evaluate response of therapy and to sort of establish, if not completely dry BNP or NT-proBNP, but also for comparison to outpatient measurements. I think that would be useful, and I think it's pretty well documented that the dry BNP or NT-proBNP is a stronger prognostic indicator in the long term than the wet acute, which is very much influenced by the volume overload.
Okay. So last question. I think we end at 9:30, but I'll ask the last one, and then I'll let the audience know that you'll be able to get what other unanswered questions will be addressed by the speakers. But the always $69,000 question is, I'm starting a new laboratory. Which should I choose, BNP or NT-proBNP, as the assay of choice for patient care? We've heard about advantages and disadvantages. Is there any wisdom, any from the three of you can provide to any of the audience?
Fred, I'll just say that the ability to retrospectively measure things is better with NT-proBNP, which makes it more convenient. Formal head-to-head comparisons haven't been done to suggest which one would be more clinically efficacious, but that's an advantage that we take advantage of in our laboratory.
Torbjørn or Kristin, any comment?
No, I agree with what Allan said, that I think there are some practical issues related to the in vitro stability, which I think is of importance. And I think if they are used in hospital setting and the time to analysis is short, I don't think it plays a major role which one you use. But as Kristin alluded to, if there are samples that are shipped from smaller hospitals, then of course the in vitro stability is an important point.
Kristin, I'll give you the last word before I read my final IFCC statement.
No, I think most manufacturers now actually have both assays available. And then it will be a practical question, or if your provider has both available, it will be a practical question, and then I think many will fall down on NT-proBNP just for practical purposes in the lab. But discuss with your clinicians; they might have use as well.
Thank you very much. I'll just add one thing to that. There's a last thing there. I'm not going to ask this to the group, but there were many questions about interferences, and Kristin did allude to the IFCC clinical application of clinical biomarkers website. There's actually table on the website, on the CCB website, that actually shows natriuretic peptides and the analytical interferences like lipemia, hyperlipidemia, hemolysis. That's published by the manufacturers. So I encourage everyone to look at that website for both the assays, as we know, not harmonized or standardized, as well as interferences. So with that, I'd like to thank all three of our speakers. I really, actually, seriously learned a lot. And on behalf of the IFCC, I'd like to thank you for attending the webinar today. Thank all the speakers, very informative discussions. I also thank the IFCC for offering this tool as an e-learning tool. It's a very, very useful tool, which I really think gathered steam since COVID, and it's really carried through. Please remember that if there are unanswered questions, they will be replied to by email to those who posted them. The certificate of participation will be provided at the end of this webinar after a few questions you'll have to answer. At the end of the questions, please click on Show My Scores. at the end of the page and get your certificate. And last, the on-demand content of this webinar will be available in short, and you will be informed of that also by email. There will soon be other IFCC free webinars, and they will be announced via IFCC communication channels, email, websites, and IFCC social media. So on that note, I thank Allan, Torbjørn, and Kristin. And on my behalf as Fred Apple, thank you very much. And I think we all say goodbye and wish you a great week forward. Thank you all.